Hi, everyone. I am here today with my multidisciplinary team regarding OSA. OSA is obstructive sleep apnea, and this is very near and dear to me. What is OSA? OSA is a medical condition that can have one or multiple levels of airway collapse during sleep. Did you know that 90% of people go undiagnosed? I'm Leila Hariri, your family and cosmetic dentist for over 21 years right here in Dubai, and now an airway focused dentist or airway architect. And I want to introduce my team before we hit this journey. Dr. Sasha, if you can introduce yourself.
Hello, everyone. I'm Dr. Sasha. I'm also part of the team. I'm ENT specialist with 25 years of experience.
I'm Dr. Gayatri. I'm the specialist orthodontist and somehow fit in the puzzle that is airway and sleep because there are multiple appliances that can be architectured. And with over 13 years of experience, this is an adventure.
Thank you so much. And Mr. Amir?
Hello, everyone. This is Obeidat, and I am the certified clinical sleep coach. I've been doing sleep since more than 20 years and very happy to join LH Clinic.
Thank you so much. And as you can see, I've been passionate about this, that we have brought all of us under one roof to help with this. Outcomes are just magnified. You know, that it's improved so much when you have a coordinated team and it's not fragmented on just one person. I want to read a paragraph out of Dr. Mark Burhan's book for you guys that sums up why us dentists, because I can see how some people might say, why is the dentist talking about airway? Well, just so you know, your bite is very much related to your airway. The placement of teeth in your mouth affects the placement of everything else, including your jaw, your tongue, your facial muscles, and throat. When teeth are crowded, the rest of your craniofacial development is crowded. Among other things, crowded teeth reduce the amount of space you have at the back of your throat, the amount of space you can use to breathe. Everything in your mouth determines how well you breathe at night, and therefore how well you sleep. I hope that sums up why the focus is on us dentists, and obviously having our ENT on board and our sleep coach, that this is the key multidisciplinary practice that is needed to be able to properly diagnose and get results with OSA. So I'm going to pass it on again to Dr. Sasha.
Thank you. So the role of ENT in sleep apnea team is assessment of the upper airway. We need to understand that the upper airway is not the rigid tube, but it's muscular, bony, cartilaginous structure, and there is interference between all these elements. Position during awake state and position during the sleep is different, primarily because we have the loss of neuromuscular tone during the sleep, where we can expect that especially soft parts of the airway will collapse. So my role in the team is to do the examination of ear, of nose, throat, area below the throat by using different kinds of endoscopic examinations. The examples of possible obstruction in this area would be obstruction of the nose because of deviated nasal septum, hypertrophy of the nasal turbinates, inflammation in this area, possible sinus problems. Then we have the mid part of the upper airway, which is the throat with the palate, with uvula, long uvula, low palate. And then very important component, the position of the tongue. I would say that in obstructive sleep apnea patients, the real obstruction maybe happens most of the times at the level of the tongue. There is a fallback of the tongue. There is a collapse at the level of hypopharynx, especially in the patients who are sleeping on the back. So my role again is to have a look at all these structures and try to identify possible areas of obstruction and something which may later interfere with the success of the dental treatment with oral appliances.
Absolutely. Dr. Gayatri?
So just to build up a little bit on what Dr. Sasha already covered, his part is to take care of your complete nasal pathway. And where me and Dr. Leila come in is the examination of the oral cavity, because all of the structures develop in conjugation with each other. And one faulty placement of one bone or one poorly developed bone or overdeveloped bone can completely change the dynamic of the face and then alter the position of the tongue, and then the tongue takes over the airway space. And this could be one of the major reasons why we have more and more kids and even adults with obstructive sleep apnea. So it's very important as dentists or as an orthodontist to understand where the root cause is. Is there a problem with an underdeveloped upper jaw, which could cause a narrower, smaller, high-arched palate, which does not allow the tongue to go and seat, or as I like to tell my younger patients, hug the roof of the mouth when you swallow? Or is it because the mandible or the lower jaw does not grow adequately, which means there is no room for the tongue to comfortably position itself, and that's why there could be a tendency for the tongue to fall back and occupy the space in the airway. Another vital structure that we would examine is the size of the tongue itself, or the relationship of the size of the jaw and the size of the tongue. That is something that makes more sense. And if the tongue is unfairly attached to the floor of the mouth, and this could even initially as the child is born be apparent in the form of a feeding difficulty, as we hear doctors say, is that babies have trouble latching on. So right from the day they are born, there are signs and symptoms that we can look into. There are different developmental stages where it's important for the patients to come in for examinations, so that the earlier it's caught, the earlier it's treated, and treatment is possible in early stages by modifying growth or accelerating growth when kids are actually in that phase of growth. So this is a very important message that I'd like to give out. Like, when the time is right, it's very important to act.
Absolutely. And if I can make a little point here, I'm seeing more and more that the tongue really is not fitting the size of our mouths. And this has to do with just over the years how our mouths are basically shrinking. And so that's why, again, dentists are the first to see this. And I'm seeing this scalloping along the sides of the tongue because it's rubbing against the teeth. Or when I have you guys open, your tongue is actually in a low posture as opposed to what Dr. Gayatri wants to see it, coming into the palate, because the palate is very high vaulted rather than being expanded. So it can't sit there, which it should be. And I'd like you to show them the swallow test, maybe, or I don't know if that is something that we want to show, but that really helps on how people swallow, because we shouldn't be using our muscles, correct, Dr. Gayatri, when we swallow. So if you are and you see that your tongue is coming out, that is not a good sign.
So if it just tends to jut out between the top front and bottom front teeth, we can surely say that that's an abnormal tongue posture. That is causing a lot of forward thrusting on the teeth, and the backside of the tongue is then not going and hugging the roof of the mouth. So when the jaws are actually growing, the palate or the roof of the mouth is not fused in the center. So the pressure that the tongue applies because of the number of times that we swallow every day, that causes proper development in the sideways or the lateral direction. And then it's one process that helps the other. So the tongue helps the jaw grow to its proper size, and then the jaw becomes a housing for the tongue itself. So if it's sticking out in the front, it's definitely not contacting the right areas at the back of the mouth, which means there is something that needs to be looked.
Absolutely. And we see that right here in the dental chair. But if I may, I'm going to say some of the triggers that cause for referral. So the biggest one is snoring. Whether you tell us you snore or your spouse tells us you snore, either way, that is a big one that we look at. Loud snoring, or apneas, which is cessation in breathing altogether, or hypopnea, which is a lesser cessation, not full on, but you have cessation of breathing or choking in the nighttime, excessive daytime sleepiness or drowsy driving. Driving is a huge one. They say that literally, when you don't get proper sleep, it's one of the worst things. And then you have episodes of micro times where you fall asleep behind, driving. You don't realize you do, and that causes so much accidents. And just brain fog. And a lot of women, kind of confuse that. Yes, menopause does this make this worse. I am jumping ahead, but in general, brain fog is not something that we want to be living with, and it could be due to lack of proper deep sleep. We'll get into that more. But there's medical comorbidities, and that is resistant hypertension, AFib, heart failure, risk of type 2 diabetes, impaired immune system. Again, all of these get repaired in our deep sleep, which I think one of us will be discussing a bit later. We have 4 parts to our sleep, and the deep sleep is by far, I think, the most important. And cognitive, mood, memory loss, and lapses, irritability, decreased reaction time and accuracy, and persistent symptoms. So, for example, high blood pressure. We just had a patient today. No matter what, he has persistent high blood pressure. So we look at that. And I think I want to pass it on because this is where I want to talk
No,
about
I'm
the home sleep
listening
test
to
and
you, but
PSG.
in children, it
Yeah.
can be surprisingly opposite. I think you will agree. The symptoms in children, instead of being too tired, they can be overly aggressive. They can be hyperactive. They still can cope with all this tiredness, and they can present completely opposite than adults.
Absolutely. Yes, yes, yes.
So that may overlap with ADHD, sometimes misdiagnosed as ADHD.
Yes.
Yeah, I just actually had a patient we were talking about her son, and he was diagnosed with ADHD. And I know I've seen him since he was a baby. And I said, you need to come and see our pediatric specialist. And it's the mouth breathing, it's the nasal obstruction, and all of that, that can be correctified with myofunctional therapy, which we also have on board. Absolutely correct, Dr. Sasha.
Yeah, I can maybe just continue with the kids. So I mentioned anatomical obstructions in the beginning, primarily that we are seeing in adults. In kids is, I would say, a little bit more simple because more than 90% of kids who present with obstructive sleep apnea, they have hypertrophy of tonsils and adenoids. Tonsils and adenoids, they are lymph tissues. For tonsils, everyone know adenoid is in some countries called the third tonsil, and this is something that people don't know that much as tonsils in the mouth. It's the lymph gland which is placed between the back of the nasal passageway and the mouth, and it's not visible by ordinary examination. It's placed behind the soft palate, and it's technically in the area that we call nasopharynx. It's like a bony box. So enlargement of adenoid can quite quickly present with the nasal congestion. These kids may cough at night a lot because of postnasal drip. And if kids have these big lymphatic structures, they simply collapse during a night, and the success of the dental treatment ultimately will not be meaningful unless you resolve the problems which are blocking permanently, because in adults it's more collapse, but in kids you have these big structures which are literally like plugs sitting all the time. And if you don't address these problems first, then I met a lot of parents who are saying that they went to orthodontists. They
3 times.
and they're saying we are doing these things for 1-2 years.
This is near and dear to me because my own son suffered from this, and that was missed. So this is why I have taken upon myself. But then these children all become mouth breathers, correct?
Yeah.
And then that has a load of...
So that's the thing. I mean, that is why it is so important to have a team just to be able to refer, so that each and every part of this factorial condition can be addressed. We all need to pass the baton when the stage is right, to the right person, so that everything along the way is at least diagnostically approached or looked at before we start claiming that one treatment is superior than the other. Now, everything that we do acts in the oral cavity, but the problems can lie beyond the oral cavity. And no matter what we do in the oral cavity, if there is a physical obstruction, as Dr. Sasha said, that there is an enlarged adenoid or an enlarged tonsil, on top of that the child has a flu, or it becomes a very prolonged
Allergies.
yes, allergies or bacterial infection, then me placing an expander alone without any help from Dr. Sasha, it is not going to work. Now, evidence wise, expanders can only decrease the nasal airway resistance. Beyond that, I cannot physically expand the airway. But once the nasal resistance is reduced and Dr. Sasha plays his part in possibly medically or surgically addressing the adenoids or the tonsils, that is when we can ensure that the pathway for the child to breathe from the nose is now open. And that's when we could possibly consider myofunctional therapy, or what I like to say is we move from the subconscious to the conscious. We intentionally train children to breathe from the nose, because it is not just a habit, it is breathing. We live because we breathe. We are alive because we breathe.
Breath is everything.
Breath is everything. So it is not completely under our control, but slowly and being very intentional about it, with exercises, with, again, yogic techniques or anything, we need to tell the brain that, look, the airway is open, you will be safe, breathe from the nose. Just a simple analogy is when all of us nasal breathers, when we go for a simple deep sea dive, and you have the oxygen tank and you have to breathe from the mouth. Why do you panic when your SPO levels are all okay? Because your brain is not yet on board. It hasn't yet understood that you're, breathing from the mouth. You're still breathing, but where do I breathe from every day? From my nose. And now I'm forced to breathe from my mouth. So it's the same analogy. When you try to tell a mouth breather, it's very simple to give that advice out that you need to focus on nasal breathing.
Correct.
But we need to convince the brain that it's going to be safe if it attempts to breathe from the nose.
Absolutely.
So that part I would literally like to focus is, I think, the most important key, or that final piece that just has to fit.
Absolutely. It's all a piece of puzzle that has to fit perfectly to get the best outcome. And dear Am, do you have any stories you'd like to share with us in regards to this?
Yeah, so from my perspective, I want to tell about different levels of sleep testing. So level 1 is the most sophisticated, let's say, type of test, where it has to be attended in a lab, a lot of electrodes and channels to be connected. Like, we monitor the activity of the brain, activity of the muscle, activity of the heart, of the respiration. We also monitor if the patient breathes from his nose or from his mouth. So we do like 6 to 8 hours of continuous recording during the night. It has to be attended in a hospital settings. And that is the polysomnography. We call it polysomnography. And that type of test is aimed actually to diagnose all sleep-related problems, not only the respiratory-related problems, but also when you talk about sleep disorders, then we have a long category of disorders, like the neurological related, like hypersomnia disorders, like insomnia disorders. It can be also psychologically related. It can be periodically movement disorders. So the category is really huge. And but the most common sleep disorders actually are the sleep-related breathing disorders. And here particularly we could say the obstructive sleep apnea. So we need to actually triage our patients because there are different levels of sleep testing. Level 1, as we mentioned, is most sophisticated for complex patients, while the level 2 is the, let's say, less sophisticated. It's a home sleep test that can be done in the patient environment, and that is aimed for non-complicated sleep apnea patients. So thanks to innovative technologies, to make the sleep test easy, or to make the sleep test easy, we have now, I'm proud to say that we have now a very smart, easy technique that we can do sleep testing without connecting so many leads on your body. It's just a single lead EEG that is to be positioned on the forehead that measures the activity of the brain, the muscles, it measures the activity of the pulse, and also the SpO2, or the oxygenation level. So it's an app that has to be installed on the patient's phone, where you can start and stop the recording, and it gets uploaded to the cloud server, where we can get it AI analyzed. So we generate the report, and then we discuss the report with the pulmonologist, or with the ENT, or the referring physician. So we can discuss as a team, as a multidisciplinary team, in order to pinpoint the root cause of sleep apnea, or the disease, and in order to, let's say, in order to personalize and tailor the treatment plan accordingly. So when it comes to the analysis of sleep study, we need also not only to talk about, let's say, the physical obstruction of the upper airway. So we need to talk about the brain control. This is something that we call the loop gain mechanism. So loop gain is actually the response that arises from the brain to react against the disturbance that might happen as a result of sleep apnea. So it's actually the homeostatic factor, to maintain our pH in a normal level. So that is also one of the things that has to be considered when we discuss the treatment plan among the MDT approach. So I would say that sleep is not actually a luxury, it's a clinical priority. So have a good sleep, you'll fix everything. So when you have sleep apnea, you will have sleep deprivation, you'll have, depression in the morning, you don't feel well, you might have excessive sleep, daytime sleepiness. There will be like a risk to fall asleep behind the wheels, right? So treating and managing the condition would really bring you good results and prevent from developing, let's say, serious comorbidities, and that could also decrease the risk of getting higher mortality rate.
And the longer you wait, the worse the condition will be with age and time. So, again, prevention, as I've always said. As I promised the audience, can we quickly just jump into the 4 levels of sleep really quick?
Yeah. So stage wakefulness, stage W, is when our brain is active, and it has 2 subtypes. The active wakefulness, as if we are looking, around, right, left, if we are staring. So this is characterized, or this is called active wakefulness. So when we are closing our eyes and we are trying to attempt to sleep, so this is the quiet wakefulness. When the brain activity is reduced within a frequency of 8 to 13 hertz, then this is called let's say alpha rhythm, or posterior dominant rhythm, that characterizes our wakefulness state. So when it's reduced further, so it's a less active, let's say, when the frequency is lower than 8, then this is stage N1. Stage N2 has the same background, which is low amplitude mixed frequency waveforms from a frequency of 4 to 7 hertz. And it's characterized by the presence of sleep signatures like spindles and K complexes. Those signatures might happen as a response to sudden stimuli. So those are responses that might be triggered because of autonomic, let's say, activation during the night. Stage N3 is characterized by, let's say, delta wave. And stage 3 is actually our juicy sleep that's more consolidated into the first part of the night. And that is the stage where we have, to dive, deeper into our dreams that we couldn't recall in the morning, because they happen more likely in the first half of the night. So the other stage is the REM sleep. REM sleep is actually the dreaming state, and it has 2 types. It has the tonic REM, and it has the phasic REM. Tonic REM is characterized by no eye movements, complete paralysis of the skeletal muscles, and that's why we don't act our dreams. So imagine that you have a full tone, right, in REM sleep, and you are dreaming, so you will act your dreams. And this is actually considered as one of the symptoms for parasomnias, REM-related parasomnias. So this is why we are deprived from the muscle tone during REM sleep. So the other type of REM is called the phasic REM where we have the rapid eye movement state. And that is actually very critical period for, let's say, patients with predisposing factors of having sleep apnea. Because of the completely paralyzed muscle tone, they get complete paralysis and they get very prolonged obstructions during the state that could be associated with more significant drops in oxygen saturation. And that could be very much dangerous, especially for patients with underlying comorbidities like coronary artery disease. So stroke, MI may happen, in the second part of the night, and those patients during REM sleep between 3 and 5 a.m.
Amazing. And if I can go back to what I was mentioning about deep sleep, a lot of our OSA patients are lacking that deep sleep. And deep sleep is where our memories consolidate, everything we learned from the day, our lymphatic and glymphatic system, which is the same, it's the lymphatic system of the brain, cleanses all the toxins from the day. Hence why people have brain fog and they're just not themselves the next morning. So it's that deep sleep is really, really important, you guys. And I know we've been learning about sleep hygiene, dim the lights, less blue light, put the orange glasses on, all these things. But if you have OSA, I don't want to say it doesn't matter, but it's, I could say that, I suppose.
It's adjunctive.
Yeah.
Like, it's important to follow it, but that's just not treatment or management of the condition itself. That's good if all of us do it. It's like adapting a new habit. But as Dr. Leila said, it's not the treatment, not the management that requires a proper diagnosis, that requires a proper assessment of the level of severity, whether it's mild, it's moderate, or it's severe. And accordingly, very targeted treatments. I think Dr. Sasha can shed some more light on those because those could be surgical and non-surgical, the treatments for OSA itself.
It's complex.
It's complex,
It's a
yes.
complex. So I agree. I mean, I just discussed with Amr, I remember 20 years ago when this whole area started to develop, we were very enthusiastic about surgical treatments, thinking that one single surgery is going to help and fix all problems. I remember these early uvulopalatoplasties, which were very morbid. People would recover for a long time, and then the success rate generally was no bigger than 60-70%. So it's very, very hard to tell people you are undergo one surgery which is very painful later on, and 1 out of 3 will not get better. That's why I think this new role of dentists in this field and the oral appliances is giving much better opportunities. From the ENT perspective, there are a lot of procedures which are quite easy, like the adenoids that I was mentioning. Adenoids nowadays are done with radio frequency. It's 10 minutes procedure, completely painless, completely bloodless. These kids immediately breathe better. They can go home after 2 hours. And this is something which is really worthwhile, which will tremendously increase the success of the dentist and orthodontist later on.
Thank you for that. So I just want to walk you guys through what you will experience when you do walk into LH from this screening. What is the screening? So we review your medical history. It's a very thorough medical history that we ask of you. And I hope that each one of you fills it out with your full heart. And then we give you the stop bank questionnaire. So it's 8 questions that the girls ask you regarding your sleep. So please try to be as accurate as possible because that really helps. But it is very subjective. As I'm finding out, once I see that, it doesn't mean that I say 3 or plus yeses means something or less means something else. I do have to have a little discussion with you guys. Again, look inside the mouth and we can have a better assessment after that. For children, we assess the behavior, school performance, and their growth. Okay, and that's mostly our pediatric dentist does it alongside with Dr. Gayatri. And then the next step is diagnosis. So if you ask me, I really think that almost all of us need a sleep test because we don't know. That's why 90% is undiagnosed. So we could have mild AHI, which is the apnea hypopnea index. And if you want to, go through what is mild, because I know you mentioned mild, moderate, severe, and also for children, the threshold is much less, by the way, for children. But this is really, really crucial. So the sleep test will tell us that. And that would be more of a diagnosis. Then we need to reach out either to our ENT, which he is here anyways, and he can help us with if there's obstruction in the area that he has just kindly mentioned to us, or if it's something based on what me and Dr. Gayatri will do. And now, I don't want to say the world is calling upon, but it's asked of us to help with OSA by making you guys what's called an MAD device. It's a mandibular advancement. So basically, by protruding the mandible, the lower jaw, that's the part that is movable, we're actually opening the airway. So there's way to do it. It's not difficult. Most of my patients have already worn a night guard, which is on one arch and it's quite thick. This is thinner, but it is on both arches. That's the way that we can protrude the mandible. So we discussed that and the materials and all of that. And
it's completely non-invasive.
And it's non-invasive.
Completely non-invasive. There's no prep required. There's no touching the hard or the soft tissue. It's just additive. You just have to wear this appliance in the right position. That's all.
Correct.
So it has no side effects per se. It's closely monitored. So I think it's something that one can easily adapt to.
100%. Yeah, but we need patients to do it.
Yes.
This is the key.
Yes.
Nothing gets done if our patients...
We're here for. We'll just have you come back to the
and baby
office.
steps, and we hold your hands, as you guys know. I'm going to end with the follow-up, but is there anything else in between the screening and diagnosis that you two would like to talk about?
Friendly coffee.
Friendly coffee, that always helps. So once we do, okay, do you want to talk? So you did talk about the MAD, basically. And then what is the timeline? So from the time that we deliver it?
So from the time that we deliver.
Or maybe we should go back on and what are the x-rays that we take? It's minimal, just the cephalometric, the lateral ceph.
We just need to understand what exactly is the dimension of the airway. Once we know that, then we would be able to see, that becomes a baseline and how much is it able to expand in the absence of, the tongue falling back. Does the neuromuscular coordination improve? Is the muscular control on the airway better after all of these treatments that have happened? So that becomes a baseline along with the sleep test just to evaluate the volume of the airway as a before and after. And the main thing is, as the patient walks in, like you said, they fill out the questionnaire. That's again a baseline test. Then we do our screening.
That's subjective. And then we do our objective
which
test.
is objective. And then I think once we see a substantial score on the stop bank questionnaire and, the oral signs and symptoms that match, or the history, the most important that you guys tell us, or, medical history, what are the comorbidities? If you have a cluster of conditions that definitely goes hand in hand with OSA, then both of us are confidently able to tell you that you definitely need a sleep test.
Correct.
Once the sleep test is conducted, which is a home sleep test, again, it's available at the clinic. And we would be able to give you the results as early as the very next day.
The very
Thanks
next
to
day,
Mr.
yes, yes.
And then we just make Dr. Sasha look at the x-rays. We all look at the sleep test. If there's any other cause that needs to be eliminated, we do. Then we see, again, coming back to the mild, moderate, severe, The mild, moderate, and severe, all three can be now treated with MAD devices. There are newer devices that also help us treat severe sleep apnea, which was until a few years ago still not very advanced research yet.
Correct.
So
And they're FDA cleared.
and they are FDA
And
approved.
they actually help the airway adjust
The morphology of
Correct.
the airway improves because there is a craniofacial adjustment that happens with using these appliances.
And the most important is they don't have to wear it for life then.
Yes.
It could be as little as 1.5 to 2 years, and maybe
Yes.
then they don't have to wear it.
Yes.
Yeah.
But even then, I mean, even if it's longer, it's shorter. As
Absolutely.
we said, we're here to hold your hand through it
Yes.
because
And your health matters.
and the health matters. So once we've decided that the patient is a candidate and everything else is ruled out, then we go into the steps for fabrication of your sleep device. It's not very different from your standard orthodontic record taking, which involves a bunch of photographs, couple of x-rays, and then a scan of your jaw and a little protrusive bite. Once you start using the appliance, we see you fairly regularly. The usual
1
8 to
week, 1
10
month, and then
yes.
6 weeks, and yeah.
So the usual initial assessments are just qualitative feedback from you. Are you feeling better? Does your partner report reduction in snoring or any of these apneic or hypopneic episodes? And I think it might be fair to get another sleep test just as an objective understanding that you are getting better and there's nothing else we need to offer, or there is no other specialist or doctor that we need you to consider if it is redundant or not improving in response to the device itself. So yes, all options are open. I think compliance and long-term monitoring is the key to understand which treatment modality is best suited as well.
Yeah.
And yeah, just follow it from.
So I want to make a big point here that many of you have heard about the CPAP and you're like big no to it. And that's why we're here to help. But it is still the gold standard. I will put it out there. If you need it, and if you use the CPAP, and we give you the mandibular advancement device, the MAD, we can reduce the airflow, which is what I think bothers people with the CPAP. Is that correct?
The pressure,
With
yes,
the pressure, with the MAD. So you can have both of them together. Or as Dr. Gayatri mentioned, now there's a company that's FDA cleared that can give us the severe, that is approved for severe OSA. And you can use it and it works. I mean, you know, and the truth about it is that it reforms and reshapes the structure of, you know, the airway so that you don't have to wear this for life. Because the traditional mandibular advancement devices, you did have to wear it for life. Not that I'm saying that's a bad thing, but I think we're always looking for better and improvement. So if the CPAP scares you, please do prevention, because if you wait longer, then the chances that you may need the CPAP alongside the MAD just becomes more and more. Yeah, can I say that truly? So the follow-up part is, again, reassessing the symptoms, subjective and objective, and doing long-term monitoring, which is what we're all about. So yeah, so I talked about combination therapy, just the oral appliance itself, and any other thing? Anybody else wants to put out there?
Maybe I think we missed to define the grading of obstructive sleep apnea, because we were mentioning mild, moderate, and severe. So I will just briefly say, medically, apnea is defined as cessation in breathing longer than 10 seconds. So for people who are having couple of seconds of shortness of breath, or you know, the spouses can notice, or parents can notice that the kid stops breathing for 2-3 seconds, this is medically not apnea, should be longer than 10 seconds. Up to 5 apneas per hour are still considered medically physiological, meaning that they can occur because of position of the head, some kind of extra tiredness, even kind of spicy food, consumption of alcohol at evening, and this is something that we tolerate. 5 to 15 of these per hour is considered mild. 15 to 30 of these is considered as moderate, and more than 30 of these per hour is considered severe. So can you imagine when we say severe sleep apnea, these people literally stop breathing more than 30 seconds per hour, not per night. So you can imagine what kind of level of tiredness the next day they are going to feel. For kids, we have less tolerance. So for kids, apneas, because of different anatomy of the airway, are not natural by any means. So even more than one is considered as mild sleep apnea. So for kids, we say, even we have this rule of 5 where up to 5 apneas per hour are considered mild, 5 to 10 are moderate, and more than 10 per hour is considered as severe sleep apnea.
Thank you, everyone, once again. And thanks to our audience, especially for listening to the end. Hopefully, this shed some light and helped you all or your loved ones. Until next time, stay safe. And any questions you have, you know where to find us.